I'd like to thank the AIOS Scientific Committee for giving us this opportunity. I kindly request Dr. Lalita ma'am, Dr. Revati ma'am, Dr. MRD sir and Dr. Mangala ma'am to come to the stage for conducting this session. Okay, ma'am. So, our talk is on Taming the Untamed, Mastering Recalcitrant Corneal Infections. We'll start with the first lecture by Dr. Mangala ma'am, who is the current head of the Department of Cornea in Arunhai Hospital, Coimbatore. Thank you, ma'am. Ma'am, I will change the order.
Thank you, Dr. Naveen. Very good afternoon to all of you. And my talk will be on risk factors and clinical features of non-resolving corneal ulcers. So as we all know, the stages of ulcer healing, in any ulcer, the treatment is started, then first thing the ulcer stops worsening, and then there is an inflammation and repair process, and then the tissue remodeling with fibroblasts and everything, finally the healing and clarity. This is a routine way of healing of an ulcer. Here we can see few ulcers which we can beautifully, the ulcers have healed with all these processes. And so when do we call an ulcer as a refractory ulcer? Because when there is no healing response to conventional therapy. So the clinical features of them will be, there will be no response to the treatment. And then the patient will not be improving symptomatically, and the defective epithelial defect and the infiltrate may not be decreasing. So there are certain time frame for different etiologies. Sometimes bugs like rare bugs like Pythium, microsporidiosis, acanthamus, they take a long time to heal. So those ulcers, we should not think that it is not healing. So that time frame of healing each ulcers also we have to keep in mind. And before labeling as a recalcitrant ulcer, the thorough, complete microbiology workup to be done. So what may be the causes for the non-healing ulcers? First thing, that may be a wrong line of therapy. Maybe without a microbiological workup, the therapy would have been started. It would have been like a bacterial ulcer which is treated as fungal or whatever. So the long line of therapy. Then inadequate therapy. Still now we see patients who are using homemade for hourly and NATA for 2 times. So we have to be very we have to explain the patient very thoroughly that which drug to be applied hourly and which accordingly we have to. So inadequate therapy will also be leading to non-healing ulcers and non-compliance to treatment. So any ulcer patients should be educated that this is going to be a long process, long journey. The patient has to come for follow-up regularly. They have to use the medications regularly. So all these things should be explained to the patient. Otherwise, it is going to be a non-healing ulcer. And also drug resistance. Even if we get a proper micro organism, but we have to find the sensitivity also. Sometimes we may be using a drug which is not sensitive to that particular organism, so that may lead to non-healing ulcers and drug toxicity. And sometimes certain ulcers like Acanthamoeba, Pseudomonas, inflammation may also be associated. So that also to be taken into account and treated. Otherwise, these ulcers may be looking like a non-healing ulcer. So last but not least, the deeply situated ulcers also, and ulcers with mixed etiology and other associated risk factors like systemic risk factors also should be kept in mind in treating non-healing corneal ulcers. And the symptoms, as we were discussing before, the patients will not be responding symptomatically. They will be worsening with persistent pain, decrease in vision, light sensitivity, and vision loss also in severe cases. So the clinical features will be non-healing epithelial defect. The underlying infiltrate will be keep on increasing. Ulcer edges will be progressive. Hypopyon will be increasing. Thinning and melting will be there. And even adjacent structures like scleral involvement will be there and associated vitritis. The clinical profile of non-healing ulcers will be like recurrence of infection, indolent ulcers, neurotrophic ulcers, and ulcers larger than 6 millimeter, deep stromal ulcers, and sometimes impending perforation. So coming to common organisms but non-healing, fungal keratitis, sometimes they will have intact epithelium with typical stromal infiltrates and sometimes only endothelial plaques. They will have a typical clinical features, but they'll be very deep-seated, and the keratic precipitates exudates over the endothelium and over the iris and anterior surface. They denote an actually deeper invasion of the fungus, and these fungus will have in these kind of infiltrates, there will be a poor penetration and accessibility to the therapeutic agents, which may lead to a non-healing ulcer. In the same way, Pseudomonas ulcer, they have a very stormy course. It's, these bugs will contaminate any substances in the earth. They have hyperacute stormy course, and they within few days they will increase and they go for melting and perforation. So in this kind of ulcers, we should not wait for healing, and then we have to react immediately. Staphylococcus aureus, this can happen in compromised corneas, and the patient in hospital admission patients, they have a relentless course, but in the same way, if it is a methicillin resistant organisms, usually they don't respond to broad spectrum antibiotic coverage, then they will be non-healing. So accordingly, the antibiotic sensitivity to be done and then treated accordingly. Also, when coming to the rare infections, we have to keep them also in mind, like Pythium, atypical mycobacteria or microsporidia. These ulcers to be taken into account. We need to know the typical features of these ulcers. Like this ulcer may be looking like a fungal ulcer or something, but when we come and see that edges, we can see that cracked mirror or windshield appearance usually happens after any surgery. It has a slowly progressive course, and it's more common after any surgical intervention. Same way, acanthamoeba infection, it can come after a wet mud injury or contact lens or due to swimming. This can be the main source of infection. Here also the course will be very chronic course in serious onset. And then many times we have seen patients like acanthamoeba or microsporidia nowadays, they come as they have been treated like a viral keratitis with steroids and other medications, and then later they present to us, and then finally we have to do, when we do a microbiological workup, we come to know that it is an acanthamoeba keratitis, and then we have to treat them accordingly. So coming to the risk factors, we need to keep the systemic risk factors also in mind. A very young patient with a fungal keratitis, the healing process will be different from a patient who is more than 60 years with chronic diabetes, along with some collagen vascular disorder. The healing process might differ. So we need to know about the nutrition condition of the patient, anemia, immunocompromised status, alcohol dependence, age, thyroid, and any oral immunosuppressants, diabetes, and collagen vascular disorders. Also, the history is very important here in treating these non-healing ulcer patients. Sometimes the infections with comorbidities, they have to be taken into account because they may alter the immune status, and then definitely they'll be intervening with the healing process. So we have to balance the therapy accordingly. Few cases, examples I've shown here. This is a patient, 55-year-old female. She came to us with a corneal ulcer, which was treated for 2 months elsewhere, and she was using these medications. Systemic history, she had hyperlipidemia, thyroid disorder, and also she was taking tablets for joint pain, seronegative arthritis. She was taking sulfasalazine, and we did a micro workup and few gram-negative Vesiligro, and other things were done. She was admitted for close observation, and we stopped all medications, and dexamethasone with polymyxin was given for 2 times, and oral doxy was started. She was recovering well. In between, she herself stopped the sulfasalazine drug, oral drug, and then she was healing much better. So here, in this condition, it might be because of the oral sulfasalazine, we don't know. We again send the patient to a rheumatologist workup, but because her other status were normal, they didn't ask her to restart the sulfasalazine. Maybe it can be because of a NSAID-induced drug melt, we don't know. So here this would have been a part, like NSAID-induced drug melt would have been a reason for non-healing. So this is another case. Patient who came with the mild pain and redness for 3 months, treated elsewhere. And here the initial photographs I don't have. She had a systemic history of rheumatoid arthritis on HCQs and prednisolone. Hypothyroidism was there. She is a hypertensive. Hyperlipidemia was there. An asthmatic, diabetic, everything for the patient. And here she had both eyes. She had epithelial defect with mild thinning and peripheral vascularization. And she also had some periocular facial pigmentation with lid margin thickening. So this was the patient's condition when she presented the first photograph, and then we suspected an ocular lichen planus, and then we did a biopsy, and the patient came positive for lichen planus. Then we have to work with the rheumatologist. The patient was referred to them, and then systemic immunosuppressants were started, and then the patient was healing much better. This is yet another patient with the lichen planus, already a known patient on MMF. And for this patient, he had an superadded bacterial keratitis, which was healing with with fortified antibiotics. But then there was vascularization. As we all know, it was a good sign. But unfortunately, this patient, behind the vascularization, there was a melt. So the panus resection was done. Then the patient was healing well. And also his systemic therapy was going on. So here also the autoimmune status and the maybe the reason for non-healing ulcer. So we need to keep in mind about ocular comorbidity also. When there is a non-healing ulcer, we need to know if the ocular surface is compromised, we may have a non-healing ulcer. So those things should be taken into account. So here it's a picture of a step pneumo with an advancing edge. So associated with chronic dacrocystitis. Once it was addressed and the surgery was done, the patient was healing much better. The second photograph, we can see a lot of dot infiltrates in the peripheral cornea. And when we avert and see the lid margins and all, we can see a lot of MGD and MGD present. And here, along with the antibiotics, mild steroids were started, and then the patient started healing. So tropic component also to be kept in mind, like diabetic corneas, neurotrophic corneas, or stem cell deficiency patients. Here we have to, because of the damaged basement membrane, the ulcers or epithelial defect may be very slow healing. So these things to be treated properly, then the process will be hastened. So last but not least is mimics of the corneal ulcer. Sometimes it may not be a corneal ulcer at all, but we will be treating as a corneal ulcer. The first one, this photograph is a patient who had a injury, and then the patient was given medicines for 5 days or a week, and then they came to us. And then on proper history taking, we found that they had an injury with a stick. Then I didn't have the AIOS2024 picture. When we did, there was a lamellar tear. So that was a tear with the corneal edema. So when we gave just one suture to that place, and then the patient healed well. And the second thing, it can be due to a toxic reaction. In this photograph, we can see a kind of a necrotic infiltrate, but luckily here we can see a small sting in that corneal necrotic area. Because of that sting, it was a toxic reaction to that sting. But many times we may not be able to get this sting or a small hair in the infiltrate. So we need, in here the AIOS2024 will help us. So we have to do an AIOS2024 and find out also the ocular history. So once that is removed, this will come down dramatically along with steroids, judicious use of steroids. And even phacolytic glaucoma sometimes can be mimicking a corneal ulcer, non-healing, and exposure keratitis. It will be looking like a florid infiltrate, but once the reason for the exposure keratitis is taken care of, and with tarsorrhaphy and other things, lubricants, it will be healed. So even a foreign body, this photograph actually, it may look like a pigmented corneal fungal ulcer, but surprisingly this is not that, and this is a small husk which was attached to that cornea. And once the husk was removed and a mild dose of antibiotics was given, and it healed completely. So they may be mimicking a pigmented ulcer, and on top of it we'll be pouring antifungals, and even the drug again it will be deposited over that, and it will be confusing for us. And the same way, chemical, thermal burns, shield ulcer, etc. can be mimicking a infiltrative ulcer, but proper history and examination will give us a clue. So this is one of another case where we can be mistook as a corneal ulcer. The patient typically presents with infiltrative abscess, and when we look for the other features, we can see a perilenticular exudates, vascularization, moderate AC reaction, and this is none other than the lenticular abscess. Here we have to do a lens cataract extraction. Along with the antibiotics, we have to give a mild dose of steroids, which will help us to heal the patient well. So this is a patient who came with the first photograph, who came with a non-healing ulcer treated elsewhere for 2 weeks. Then we gave, he gave a history of injury with an insect. So we started with mild antibiotics and even mild dose of steroids, but he was not at all recovering. And then here we could find out that lens matter also, like as I showed you in the previous slide. So then there was an lenticular abscess. We did a lens cataract extraction, and this is the second picture after the cataract extraction. Still we can see some exudates over the iris and all. After use of steroids, and the patient was healing like this. And this was the center picture, was the final picture. You can see a very good response to the patient. So this patient was initially treated with all antibiotics, antifungals, and everything. So now we have stopped, and with minimal antibiotics and steroids, he was improved dramatically with cataract extraction. So these things also to be kept in mind when we see a non-healing ulcer, like contact lens wearing, previous ocular surgery, trauma, etc. And also the ulcer profile, supraocular infection, antimicrobial resistance, refractive organisms, and any surgeries. Drug related also to be kept in mind: drug resistance, poor drug penetrations, poor compliance, low dosage, and sometimes chronic anesthetic use and steroid use also may lead to non-healing corneal ulcers. This is one case where the patient was given steroids for, the patient is a known case of NVG. Yeah, only one last slide. And was given lot of medications. So finally we have to stop the medications and do a scraping, and with minimal steroids he improved. So finally we have to assess the response to empirical therapy. There are multiple drugs, we have to try to withhold one or with one by one, and then immune and inflammatory other conditions to be taken care of, and titrate the medications and address the associated factors. Finally, if nothing is working out, then we have to go for a therapeutic keratoplasty. So it is a challenging condition with multifactorial etiology. We need to work with other specialists and for the complete healing of the ulcer, and we need very good cooperation from the patient side, because it is going to be a long journey. Thank you.
Very good. Okay. Very Now I'd like to invite Dr. Revati Madam, who is my teacher also. She will be talking about the effective treatment strategies for challenging organisms. Over to Madam.
I am going to walk through some case examples of some normal infections which presented differently, or some rare infections, and how we managed. And first let us start with multi-drug resistant pathogens. This we have to keep in mind. They are not that rare nowadays. Their incidence is increasing, especially if infection occurs in a healthcare worker. So nowadays more of post-LASIK infections are due to this multi-drug resistant organisms. It can be anything, like it can be in pneumococci, it can be in Staph aureus or MRSA, or it can be gram-negative organisms also. So these pictures are from Dr. Lalita's work in Madurai, and you can see in pneumococcus about 2.4% of isolates can be multi-drug resistant, and they are not responsive to ciprofloxacin and fluoroquinolones. So that we have to keep in mind when treating them empirically with fluoroquinolones. And the same way in Staph aureus also, 76% of these organisms are MDR, and they are 100% resistant to fluoroquinolones. And coming to Pseudomonas also, same thing, and their response to this fluoroquinolone again is very, very less. So multi-drug resistance, they are not responding to common therapy. So we have to keep in mind, and 2 drugs or 3 drugs which stand out here: chloramphenicol, vancomycin, and the ceftazidime. So when in bacteria, the response will be usually good. When it is not like that, then immediately think about multi-drug resistant and try to get a culture sensitivity pattern. If not, go for these drugs. And on the other hand, don't use vancomycin and ceftazidime as the first line therapy in case of infections, because those are the few drugs we have for multi-drug resistant organisms. Coming to the other ones, the deep fungal infection. This is a case where a 57-year-old male, only thing he had as a systemic problem is he is on steroid inhalers for his asthma. Other than that, he is not a diabetic, a very healthy person, already treated as fungal for 2-3 weeks in a different place. When he came here, the surface was healing, but a deep infiltrate and endothelial plaque kind of thing was there. So we have started intrastromal injection, voriconazole. After 2 or 3 injections, he started responding very well. And we even scraping, we couldn't find anything because it's all deep infection, and only with confocal we could find that it is definitely fungus. And 5 days later, he went back, and he came back with again the vision dropped and worsening of symptoms, and 2 new satellite deeper infections started, infiltrations were seen. IOP also started rising, and here we started oral voriconazole for him, because at this time we scraped and the culture came as fusarium. And after 3 weeks of therapy, he started responding very well, as you can see here. and he stopped. We planned initially to give oral voriconazole for 3 weeks, and he stopped the medication. Again the symptoms started worsening, and as you can see, even in the AIOS20, you can see the deep endoexudate extending towards the periphery. So an alarming sign. Again we restarted the oral therapy along with the topical therapy, and he started responding. After 8 weeks of therapy, it completely healed, and he has become clear of infection. But here the 2 points from MUT2 what we have learned. Oral voriconazole sometimes can be an additive, a good additive for topical therapy in case of fusarium. And the repeat culture after 1 week of therapy came as positive. That is again an ominous sign. So we have to, in these cases, we have to treat aggressively. Other rare infection I want to here share with you. 2 cases, both young female, presented with no predisposing factor, just an chronic ulceration with severe photophobia, and you can see not much of necrotic lesions. It looks more superficial with a lot of inflammatory reaction. And in this picture I am not able to show you, but in the posterior part of the endothelium as well as the anterior chamber, a fibrinous pigmented lesion was sitting there. So we thought more towards the fungal, and both cases were treated as keratouveitis and with oral and as well as topical steroids also. And these 2 picture I borrowed from Dr. Radhika from Shankar Nethralaya. She has seen a case like this and published also. As you can see, this is the picture what we have seen in our patient also, a endothelial plaque which is going even up to the anterior lens capsule. And this alerted us, and the scraping came to our surprise as atypical mycobacteria. No previous predisposing thing, anything here. So we have after consulting with infectious disease person, we have started around oral clarithromycin also, along with topical clarithromycin and amikacin and minocycline. And he advised us to go ahead with the treatment for at least 8 weeks. And we have done that, and she completely responded after 3 months, completely cleared. The similar way in few weeks time, another female we have seen with the same picture, but with a history of some fall of insect. Again the culture report came as atypical mycobacteria, and here we straight away started the oral clarithromycin, and then she also started responding, and we have given it only for 3 or 4 weeks, and by the time she healed completely. So we have to keep in mind, in atypical mycobacteria always need not be a typical picture like this. It can be even without any predisposing history, and once you recognize that, no steroid for these patients, and oral therapy is really helpful in these patients. And microsporadial keratitis, again we all know, microsporadial stromal keratitis is very difficult to recognize and often mistaken for viral, but the typical clinical picture will be a granular infiltration, some mistiness in the stroma without any necrotic lesion, and this will keep on spreading. And this young female, she is on for immune nephritis, she was on oral steroid already, so very less toxic reaction and only inflammatory reaction, only this kept on spreading. And the confocal picture, you can see the typical rice-like bodies within the intracellular bodies. This is a very typical histopathological like kind of picture. And we went for, because we have to plan for a surgical intervention, we went for a corneal biopsy to prove it, and it came as positive for rice bodies. And then we went ahead and did a large therapeutic DALK here, because we have to go up to the limbus. But at present she is okay, but in these cases sometimes the recurrence can come, and she may need a full thickness keratoplasty later. It is possible, being reported from other centers. The last one is acanthamoeba challenge, what we are seeing nowadays. Handful of cases I have with immediate scleral invasion, and they are behaving very badly, and it's not like the usual acanthamoeba, so slow smoldering infection. They progress very fast. This is one young boy with contact lens misuse. He came with this, and within a few days the picture became like this, and it was going towards the superior limbus. So actually here also we have to go for a lamellar cut and take the material from deeper layer to prove that it is acanthamoeba. And then we have started him on 0.08% PHMB, which is being recommended nowadays. And in addition, because this infection is so bad, I have added double biguanide, another chlorhexidine also, and also oral voriconazole, which is being recommended by Dr. Elmer too from UAC. Because here I want to try everything possible to save this boy's eye. And finally he started responding, and even AIOS picture also started recovering well. Now after tapering the biguanides, the vascularization also came down very well. So then why we have to be aggressive? This is another example, another young man. A picture was like this, well demarcated also. We went ahead with a therapeutic graft, but what we are seeing is a non-healing ED and again a reinfection. And not only that, a severe cyclitic membrane in the he developed, and the eye was started going towards thysis bulbi. And then we repeated the graft, and we have injected a silicone oil, and we are trying to save the globe for him. And the scleral invasion also occurred immediately after that, before the SOI. So nowadays, I don't know, the last few months we are seeing acanthamoeba in a very aggressive manner. So the reason may be from the initial infection, it can be a inflammatory response. The scleritis, dacrous adenitis we have seen in a young lady, and sympathetic ophthalmitis also being reported. Or it can be intense parasitic invasion itself, which can cause all these things, scleral abscess, endophthalmitis. We have seen a series of post-op endophthalmitis after acanthamoeba. And so these things can occur in acanthamoeba, and acanthamoeba not always a ring abscess which is there sitting for months together and being treated as viral keratitis. The picture can be very different, and sometimes we have to be very aggressive. And not only that, the toxic reactions like cataract, anterior segment ischemia, or even posterior segment ischemia can occur due to either the toxin released by acanthamoeba or the drugs itself. So sometimes we have to go aggressively for acanthamoeba treatment. So in conclusion, keep rare infection also in mind when the response is not what you expect. A methodical microbiological workup is very, very important. And we always think about multi-pronged therapy when the response is not good, oral and other therapeutic options also. Thank you.
Any questions from audience for ma'am?
Sir, biguanides only, either chlorhexidine or PHMB. And the recent report from Moorfield suggests that 0.08%, because previously we used to use 0.02% or maximum 0.04%. But now Dr. Dart and his team reported that 0.08%, if you start with aggressively, then the response will be better. But that's what we are even now studying as a randomized controlled trial. But what I observe with 0.08, there is some definite drug toxicity is there. And this handful of patients whom I have seen recently, they are, even when they come only, they are very aggressive. Within few days I can see the scleral involvement. So I don't know, now the acanthamoeba, I feel it's behaving differently. But the first line of therapy will be one of the biguanide, either chlorhexidine or PHMB. Yes, that we have to get the medical grade. I think Lalita will.
Yeah. Actually, Orolab is now, it's available in Orolab. If you go to the Orolab website or contact some Orolab dealer, they are selling the concentration as 100%. I don't know whether they're selling it as a diluted. Are they selling it as diluted one?
It's reconstituted. Powder will come.
No. They sell it in the solution. So it's just very easy. You just have to just take 20 microliter of the drug and just mix it in 20 ml of distilled water. So that is for 0.02%.
Okay.
So 0.04 means you just double it. So just 20 drops. If you don't have a micropipette, just take 20 drops of the drug and 20 ml of distilled water.
Okay, thank you.
And it's available in Orolab is giving it.
Because I'm practicing in a small town, sometime facility of culture and all these are not available. and many patient came with so many taking treatment from rural areas, different drugs. So what should we prefer in that case? In bacterial, sir, multiple means.
Bacterial ulcers.
Yeah.
If already they are on multiple drugs, generally what I would advise, you first stop all the medication and see, and maybe like if you are very convinced it's bacterial, just start with, usually if it is a significant ulcer, you have to go for a fortified cephalosporin or something which are relatively less toxic, and start that, and then you see the response. Accordingly, like if necessary, you can add any other drug. Otherwise, it's better not to allow them to continue with multiple drugs. Sometimes the drug toxicity itself will not allow the ulcer to heal.
Will it be means ceftazidime and amikacin both we
No,
can give?
ceftazidime you always preserve for multi-drug resistant pseudomonas. Cefotoxime will do.
Okay.
Cefotoxime, amikacin we can use.
Okay. And what about tobramycin? For
Tobramycin also we can use.
we are making fortified preparation. In 3 ml vial, we are injecting injection
Injectable
of
form.
tobramycin or
Yes,
amikacin.
yes. That we can use. Yeah, Tobra also equally good only.
Thank you, ma'am. Thank you.
Thank you, madam. So now I'll call upon Dr. Naveen for this managing of non-resolving corneal ulcer, the adjuvant modalities of treatment. Naveen, over to you.
Thank you, sir. Thank you for this opportunity. Why do we need adjuvant treatment modalities? One, there is a increase in incidence of multi-drug resistant organisms both in bacteria and in fungal also, and there is a paucity of antimicrobial drugs. Natamycin, discovered in 1960s, is still the drug of choice for fungal keratitis. We have not received newer antifungal therapy for treatment, and a patient, because of the barriers in care, can present to us late, which by those features can have poor prognosis for medical therapy and might require therapeutic penetrating keratoplasty. So the adjuvant treatment modalities can be broadly classified into drug delivery based modalities and phototherapy based modalities. In the drug delivery based modalities, we will discuss systemic antifungals, intrastromal and intracameral injections, and in phototherapy based procedures, we will describe PAC-CXL and rose Bengal photodynamic therapy. So oral voriconazole with a loading dose of 400 milligrams twice daily for 24 hours, followed by maintenance dose of 200 milligrams twice daily, in addition to topical natamycin and voriconazole, was found to be not effective in severe filamentous fungal keratitis. However, in fusarium cases, there was reduced risk of perforation, and the need for TPK and the reduced scar size was seen. As ma'am had mentioned, we need to be cautious when we are giving oral voriconazole. We need to watch out for the visual hallucinations in these patients. Another study from Coimbatore, where they have studied oral ketoconazole in addition to topical natamycin, and they found again there was no added benefit. Coming to the intrastromal and intracameral injections, these are the commonly used drugs. Voriconazole is the most commonly studied drug for intrastromal injection, followed by amphotericin. There are a few case series where they have used moxifloxacin and cefuroxime for recalcitrant bacterial keratitis as intrastromal formulation. So this is the largest randomized control study which included 70 patients, and they found that patients who were randomized to intrastromal injection had worse outcomes, even though the difference was not statistically significant, and there was increase of 2.85-fold hazard for perforation. From AIOMS, they came up with a novel formulation of water-soluble natamycin, which can be reconstituted to 10 micrograms in 0.1 ml and used as an intrastromal injection. And in their study of 20 patients, 19 patients healed with injection, and of whom 13 required just one injection. We are waiting for that to be commercially available. Amphotericin can also be used as intrastromal injection. The only issue is it can lead to deep stromal vascularization, and the availability of amphotericin is another issue. Coming to the phototherapy based procedures, the first is the collagen cross linking, photoactivated chromophore for keratitis, PAC-CXL. So here, because of the reactive oxygen species development and UVA, both have antiseptic effect, and also the collagen cross-linking can increase the covalent bond formation and reduce the risk of corneal perforation and melt. So numerous case series have studied and showed that this is effective in bacterial keratitis. It was also studied as a monotherapy without antimicrobial, and they found that there was no time difference in time to reepithelialization. When we did a randomized control trial in smear positive bacterial keratitis, we randomized the patient to receive standard microbial therapy, that is moxifloxacin, and one arm having collagen cross-linking and the other arm having sham cross-linking. And we found that in bacterial keratitis, there was a decreased 24-hour culture positivity and fewer corneal perforation, but the results were not statistically significant. That led us to a large volume NIH funded international randomized control trial, where we randomized patients who were smear or culture positive bacterial ulcer into 3 groups. The first group is only topical antibiotics, that is moxifloxacin. The second group is topical antibiotics plus topical difluprednate started 24 hours after the initiation of antimicrobial therapy. And in the third group, along with topical antibiotic, topical steroid and collagen cross-linking. So we recently concluded the study. 280 patients were included, and there was no evidence of benefit of topical steroids or collagen cross-linking, and the scar size was minimal in patients who received the steroid group, and the incidence of corneal perforation was similar in all the 3 groups. This has been submitted to JAMA Ophthalmology, and we are waiting it for it to be published. We also tried adjuvant collagen cross-linking in fungal keratitis. So we initially recruited deep stromal fungal keratitis who did not respond to therapy for first 2 weeks of antifungals, and we randomized them to receive either collagen cross-linking along with antifungals or only antifungals, and we found that the perforations were more common in the collagen cross-linking group. Therefore, we concluded that collagen cross-linking should not be used in deep stromal fungal keratitis. So we thought, okay, fine, in moderate fungal keratitis, whether it can be used. So patients with vision of 20/70 or worse and not involving the posterior 1/3 of corneal stroma, we included them. We randomized them to 4 groups: natamycin plus collagen cross-linking, amphotericin plus collagen cross-linking, natamycin with sham, and amphotericin plus sham. Because in vitro studies have shown when collagen cross-linking was combined with amphotericin, the in vitro effect was better. And we also found that in patients randomized to collagen cross-linking group, there was an increased odds of 24-hour culture positivity. That is, the microbial load was more, and but there was no difference in the scar size or adverse events in the 4 groups. And at 12-month follow-ups, the BSVA visual acuity was worse in patients who were randomized to CXL, either irrespective of whether it's natamycin or amphotericin. The next phototherapy is the rose Bengal photodynamic antimicrobial therapy. Here, instead of riboflavin, we use rose Bengal dye, and it is activated by green light that produces free oxygen radicals which have antimicrobial effect. So 0.1% rose Bengal diluted in 0.9% normal saline is used. We have a loading dose for 30 minutes. The drug is applied every 3 minutes, followed by application of green light, which is from a custom-made LED light source, for 15 minutes with continued application of rose Bengal. Since no UV light is used, there is no damage to keratocytes and endothelium. So we get the rose Bengal as a lyophilized powder, and that is mixed with normal saline under red light, because the green light in the normal daylight can activate the rose Bengal. So we don't want that to happen. And this is the custom-made machine from University of Miami. And first 30 minutes under red light, we apply the rose Bengal, and in the last 15 minutes, the green light is shown to activate the rose Bengal. So case series have shown that this is effective in bacterial keratitis and in fusarium keratitis. However, the treatment is not good with aspergillus keratitis. We have recently completed a large volume randomized control trial where we randomized the patients of smear positive fungal keratitis, acanthamoeba keratitis, and smear negative corneal ulcers to receive either the topical antimicrobial or topical antimicrobial with rose Bengal photodynamic therapy. and we had included 330 patients. We have concluded the study, and we also found that there was no statistical difference among the best corrected visual acuity at 6 months between both the groups. However, it was slightly beneficial in fusarium. So to conclude, there is still an unmet need for adjuvant treatment options for recalcitrant keratitis. Oral voriconazole is beneficial in fusarium keratitis. Intrastromal voriconazole does not have an added benefit. Collagen cross-linking is again beneficial in bacterial and acanthamoeba keratitis. Rose Bengal photodynamic therapy is again beneficial in fusarium and bacterial keratitis. Thank you.
Any questions?
Using intrastromal or completely you stopped doing that?
We are using them, but we are noticing that patients who have undergone intrastromal, like we did another study, it was a retrospective study, 40 patients of deep stromal corneal ulcers with endoexudates who underwent both intrastromal and intracameral voriconazole injections. So of the 40, 17 had resolved, but the remaining 23 had worsened to TPK. And when they go in for TPK, because of the increased antechamber inflammation, what we are seeing is the postoperative outcome following TPK is very bad with respect to the secondary glaucoma or shallow AC, endophthalmitis, lens expulsion. These are more common in these patients. We have submitted that to IJO, it has been accepted for publication.
Yeah, even that's the thing. Usually intracameral I'll be very cautious. It definitely increases inflammation, both amphoby and as well as voriconazole. But intrastromal, again, I would suggest once or twice we can try. If you see some good response, maybe, and otherwise, no point in keep on giving it for several times. And sometimes we have seen worsening also with the injection. Then in that case, better not to.
Yes. Thank you.
How to give intrastromal injection?
So for voriconazole, it is 50 micrograms in 0.1 ml.
Yeah,
so
so
we the preservative-free voriconazole comes as a 1 milligram vial. So we need to add 4 ml to it. That will and from that 4 ml you need to take 0.1 ml. So 0.5 ml. So that will have a concentration of 50 micrograms in 0.1 ml. So and in topical or peribulbar anesthesia, the injections are given with a 30 gauge needle, the hypodermic needle, around the margins of the ulcer to see for the stromal whitening when the drug is injected. That means that the drug has penetrated that area.
Again, it's available as preservative-free ozole in our lab for intravitreal injection. The same one we can use for intrastromal.
Next, I would like to call Dr. Lalita ma'am for her talk on recent advances in microbiology, rapid diagnosis, and for corneal infections.
Good evening, everyone, and thank you for coming to our instruction course. So I would be talking on recent advances in microbiology with special emphasis to rapid diagnosis for corneal infections. So actually currently we are in a very exciting time where so much rapid progress is being made in the diagnostic field in microbiology, especially for corneal infections. So our institute is, Arvind Eye Care System is doing a lot of studies on this. So as we all know, microbial keratitis is a very, very important cause of blindness, and there's a varied range of etiology. And as a cornea specialist, everybody's, this thing would be to have a real very good diagnosis, the actual exact diagnosis, and also predicting the prognosis also. So if such a tool was available to anybody, that would be the ideal thing to have. So that's what we are trying to aim in doing in our lab. So before that, I would just very, very briefly talk about the conventional system, what we have, and then go on to the rapid diagnostic modalities that we are trying to work on. So as you all know that empiric treatment is still followed, and it's still okay with if you're going to see a lot of bacterial ulcers in your practice. But however, many studies and many experiences have proven this is not so good in our situation. So I just want to show share the data from our lab. So as you see, we have a culture positivity of around 51 to 52%. So at least in this 50%, we are happy, even if the patient is not resolving or some other complication is there, at least you know that you're dealing with some kind of definitive microbiology culture proven cases. But what about the rest 50%? So that's where the real challenge is, and that's where we are focusing all our diagnostic research purposes on that. And then also we know that the profile of all the organisms through conventional microbiology. So this information is known to most of us. So coming to the conventional microbiology, that's still the gold standard. So you just, whatever technology is coming, whatever the latest things are coming, we still cannot do away with conventional culture with all the problems it has. So we definitely require culture for identification of the organism, and also for the antibiotic sensitivity testing, and for so many other reasons. And among conventional culture, which includes direct microscopy and culture, direct microscopy is so important. So I really want to take a minute to emphasize on the importance of direct microscopy. So it's rapid, preliminary results are available, very inexpensive, and can be performed by everybody. So all the cornea fellows who are trained at Arvind, we try to teach them on how to do a gram stain, how to do a KOH, and how to mount the microscope and identify these common organisms. Like sir was asking, even if there's no microbiology lab, or even if there's no microbiologist, even if your optometrist or technician can be trained in this, that's going to be so useful. So even if you know immediately whether fungal filaments are seen or bacteria are seen, that is enough for you all to start treatment. But the problem with conventional microbiology, culture takes time, and sensitivity, as I showed you just now, it is only around 50%. So that 50% is, I think, is more or less uniform across many labs. I have this thing. So I don't think sensitivity is going to go up above more than 60%, even though you're whatever place you are in, whichever lab you're going to use. So microbiology laboratory is also not available, and the need of the hour is more quicker and accurate diagnostic tests. And also right now, what is of importance and what is of urgency is the point of care. So as we all are aware, most of our patients are all from agrarian and rural areas. So they would first go to a primary health center or a vision center. Now most of the areas have got vision centers. So we want some diagnostic kits which can be used by the vision center technician itself. Because patient might come to us or come to you all only after 2 days, or even after 5 days, or even after 1 month or whatever. So right now, what and all are the combination of things we are having is molecular diagnostic methods, which is conventional PCR and real-time PCR. This everybody is aware. So for the past 20 years, now PCR is more or less become quite common in most of the labs. Now the next thing which we are working on is something called next generation sequencing. So I'll just share what it is next. And then next is called personalized medicine. So most of the meetings you go to, especially in the microbiology meetings, or if you go to all these immunological meetings, everybody's talking about personalized medicine. So although all the speakers were saying this works for Fusarium, this works for Aspergillus, this doesn't work for bacteria, now we are going to take it one step higher and say, even if it's Fusarium, for this X patient, this doesn't work, or this will work. So we want to go even deeper to have a real personalized treatment for each and every patient. And then we have smart probes and lateral flow assays. So these are what is going to be the point of care. So they're going to be coming out as very small kits, which can be used by, just take a fluorescent strip of the ulcer, take the material from that, and then so I'll just show you some pictures on that. And now artificial intelligence is everywhere. In fact, tomorrow we've got series of talks on artificial intelligence. So even our lab is working on something to develop that for gram stain and KOH. So you don't even need a technician. So suppose if you just do the stain and focus it under the microscope, we have a software, that's what our lab is developing. That software will tell us whether fungus is there or bacteria is there. And then finally, we have something called CRISPR. So I don't know whether everyone's aware of this latest technology. In layman's terms, it's called gene editing. So it's used so much now. It's come in diagnostic kits are available now, especially in the cancer diagnostics. So that can predict whether cancer is there, prognosis and all. So we are using CRISPR technology for diagnosing fungal keratitis also. So PCR, as I will just not spend too much time, I just want to take time to say that it's a lot of problems with PCR. Next generation sequencing, we just sequence all the data which is there. So you don't have to, it's not like PCR, look for fungus, it can just look for every organism which is there. And then this proteomics, tier proteomics, our lab does a lot of research on tier proteomics, and we are trying to come up with bio molecules which can be used as diagnostic, prognostic and therapeutic also. And this is the point of care which I was talking about. We just got it published 2 years back. So this is a very, very small kit, like a pregnancy kit or like a HIV dot kit. This is now available only for aspergillus. This has got a very good sensitivity. So now we are working with the company to come up with kits for fusarium also. And this is the probe thing. And AI, so we just got it published recently now. So this is, now we are going to just scale it up with using more samples in this. Now CRISPR, I will just be very, very brief in telling you this. This is actually it's an immune mechanism which is there in the bacteria itself. So the bacteria has got this capacity to edit any foreign genes that get into it. So we are capitalizing on this technology which the bacteria has itself to help in identification of other organisms. So we published 2 papers on fungal keratitis and fungal endophthalmitis using CRISPR. So finally, to conclude, I think in future we are going to have a multidimensional approach to diagnosing any ocular infections. So conventional microbiology is still going to be there. And as I said in the beginning, point of care, NGS, targeting biomarkers, artificial intelligence, and CRISPR. So that's the future of microbiology, which I hope will come sooner than later. Thank you.
Any questions?
Dr. Lalita, in the other session also, they were talking about antifungal sensitivity testing also.
Yes, yes, yes.
Nowadays, more and more people are suggesting that. And do you think where we are standing in that?
Because the problem with antifungal testing, even if you're going to do it for one fungus, it's going to take you minimum 5 days. Because you have to wait for the fungus to grow for the MIC to be visible. So whether you want to willing to wait for 5 days for the report, and since the volume is so large, it's very time consuming. That's the only, it's not very expensive. It is very, very cheap only. Only problem is time consuming. You need technicians dedicated to that. But more than that, I don't know whether so many studies have shown that MIC really doesn't matter for fungal keratitis.
Yeah,
I
correlation, clinical correlation is not there. And another thing, as you said, the fungus, of course, we have to start the treatment immediately. And as you said, only if you get the culture positive, we can do this. There
Yes,
is
yes,
another
yes.
40 to
50% nearly.
group which is negative. And in that, what we are going to do? We can't wait for the sensitivity
You'll just
pattern.
have to empirically start
And
treating
another
those
thing,
patients.
the number of antifungals available.
Is
Only 2 groups are available now,
Yeah.
azoles and polyenes, and what is there much to choose among them? That
yeah,
is also
although
there.
for research
Anyway,
purposes, we do so many antifungals, but all of them are so expensive. It's not worth like all this mycofungin and posaconazole, and we test for everything. Now even that immunomodulator drug, no, the ticoplanin, that's also we're trying to do the sensitivity for. But I don't know whether you can go to use ticoplanin for this thing.
Thank you.
Thank you.
Finally, I call upon Dr. Manoranjan Das sir, for a talk on techniques for successfully performing therapeutic penetrating keratoplasty in non-resolving corneal ulcers.
So good evening, all of you. So after and at the outset, I would like to thank the APO and AIOS committee to having accepted our IC for presentation here, and I would like to thank Naveen for giving me this opportunity to be part of AIOS. So after having discussion thoroughly about starting from definition of non-healing ulcer, the risk factors, what is precipitating the non-healing features. And second, we went ahead with the madam's presentation about how do you manage the critical cases which is goes beyond your suspicion. And the third, we went ahead with the, along with the treatment for modalities of maximum medical therapy, we have gone for the adjuvant therapy starting until reaching up to the phototherapy. And next, the madam nicely highlighted the role of the recent diagnostics to go for the management. Or next is main topic. So as you all know, the conventional treatment of any non-healing ulcer is surgery. So that is how we don't want, actually, because we know that surgery is not a great point to do. It has got its plus and minus also. So corneal opacity represents the 5th leading cause of blindness globally, and the recent WHO study says about 6 million population in the world around affected with the corneal blindness, and infectious keratitis is the main culprit of the blindness. The infectious keratitis is caused by a wide variety of organisms like bacteria, fungi, protozoa, viruses, etc. The higher incidence of infectious keratitis is attributable to poor environmental and personal hygiene, lower level of education and agriculture-based industries, work-related or trauma-related episodes, and the poor access to the sanitation and healthcare facilities. So, by definition, therapeutic keratoplasty is a surgical procedure in which the part or the all of the damaged diseased cornea is replaced by a healthy corneal tissue with a primary aim to eliminate the infection load and to establish integrity of the globe. The secondary aim, of course, is the vision. So, this is a therapeutic typical microbial profile which is done by clinic profile picture. The study is done by LBP group, and this includes from 2016 to 2021 in the eastern part of the India, and they have found out over that 5 years they could have seen about 13,000 plus microbial keratitis, out of which 3,000 plus went for TPK, roughly about accounting about 23%. So this is how we have seen the profile, that the blue color represents the fungus, red color represents the no growth, and the bacteria represents the green color. The majority is chunk is responsibility is due to the fungal infection. We have got this spectrum of antifungals, but still the presentation of infectious keratitis can be varied way. We see them with a small stage, the small ulcer central, then it subsequently progresses to subtotal, and then total ulcer, then perforation, and then melt with uveal or lens prolapse. So that is already highlighted by Naveen, that intrastromal voriconazole and Arjun had no offer, extra beneficial offer to give for non-healing fungal keratitis. This is one study which was done long back by our hospital, by showing that the collagen cross-linking therapy was also not helpful for deep stromal fungal infections. So this is a video. So if it is not helping us, then what will help us? So this is how we waited for the treatment. And this is a well centralized ulcer, the stromal abscess, so we had waited for all maximal therapy, so it went for a perforation with uveal. So for that point we could decide to go for a TPK, because we had a very healthy rim of more than 1 millimeter, so it was very helpful for us to secure the globe and restore the anatomical integrity. So this is how it will, after the end of the surgery, AC is well formed, and you can give intrastromal, intracameral voriconazole if you want, for all these cases when fungal ulcer is proven. So this is how it was day 5 post-op I discharged them, and you can see, because you use a optical grade tissue in this, and the 3-month post-op, it looks really good. but all that affects you won't get in all cases. So how to improve the conventional outcomes of the TPK? So major thing for TPK is a good block. Whether you achieve it by the general anesthesia or local anesthesia, it is your choice. And another major component which hinders in the effective finishing of a TPK is the positive pressure management. So positive pressure management can be done by pre-op, starting with oral Diamox or acetozolamide, and then intra-op you can take the patient under IV mannitol. Subsequently, you feel the patient and have a touch for the eye and see that whether it is tight or hard at the globe. Then you can do a vitreous tap to decrease the ocular pressure. Of course, for large ulcers which needs better ream for suturing, you should do the peritomy and then start suturing after the surgery. So this is how few cases which is early detected can go for a therapeutic DALC. So therapeutic DALC is a noble procedure, but only thing is that it cannot be used for all type of ulcers, and you should be very specific, and you should have some adjuvant devices and to find out the depth of the ulcer. So here we have taken a non-receiving nocardial keratitis with about anterior restricting about anterior 2/3 of the cornea, and the depth was very nicely seen with the confocal microscopy. You can see we have seen that beaded filaments at here at about 88 microns, and here next is about 192 microns. Beyond that it was all free. So we decided to go ahead with the therapeutic DALC, and this is how the procedure can be done. It was looking a wreath pattern, well circumscribed and central ulcer, so it was easy for us to delaminate. So we have gone almost like up to probably 300 microns depth, and during the surgery you can always assess the residual bed. That is how you can know how much depth you have gone. We need not do a deep lamellar keratoplasty. It is almost like a little bit of anterior lamellar keratoplasty going up to 2/3 of the corneal stroma. So once you take it out, the infective part, because you know roughly about 192 microns it has gone penetrated into the stroma, so you can have a guarded knife also, 300 microns guarded knife, to make a round cut, and then you can go ahead, which will be more precise. So after this, then you can replace your optical, you can replace any therapeutic grade button, and you can always check out this Desper's membrane. You can stain it for your better look, and you need not stain it also. You can just peel it like that. But you take a clear cornea a little bit, so that the post-op edema it won't be there. This is how we have got a good more than 1 millimeter rim from the center of the ulcer all around. You have taken about 8 millimeter of graft, and then is stitched on the residual stromal bed. You can give also the so you can go underneath and just give a voriconazole wash little bit, and you can leave it also, or you can leave it like that also. So this is how the integrity of the globe is secured with a better visual outcome. So you can see that the post-op, immediate post-op, about 7 days, and this is about 2-3 months. You can see the amount of corneal residual bed it is left out. So even if you give the full thickness cornea here, it is almost like this will be almost like 1/5. That means about 100 to 150 microns has been cornea has already left, and this didn't show any recurrence. So the therapeutic outcomes of TDALC has been compared, a study long back by the SNSC group by also Arundhati and Anand Partha. And they have, of course, they have taken a lot of bacterial keratitis as their marker, and they felt bacterial keratitis, the T-DALK was better. For similar studies are done for lamellar fungal keratitis in Chinese group, and they have found out the recurrence of corneal ulcer is seen in aspergillus, steroid, and the cases which are taken pre-op with hypopyon and endothelial plaque. So they also added one observation to that fungal hyphae pattern is more important for the recurrence. So where they have found out that hyphae who grown horizontally, like fusarium hyphae in the corneal stroma, has less recurrence than the aspergillus who vertically grown into the corneal stroma. So however well surgery were done, you should be lucky enough to get rid of this TPK. TPK primary, as I said, the primary goal is to get rid of the infection. Next secondary goal will be then site. Site is not important. So you can see whatever best you have done, many cases we have seen the recurrences, and many cases although there is no recurrences, final outcome will be 360 vascularization with failed graft and bullous keratosis, secondary glaucoma. These are all the miseries of the TPKs. All that is seen in the or placed in the paper or pen. It doesn't happen in the normal way. I think the presentation time, the accessibility of the patient to the tertiary center for frequent visit and treatment, and correct timely surgical intervention can probably prevent this type of consequences which is inevitable in the late stage of TPK. Thank you for your kind attention. So the take-home message for this is corneal opacity represents fifth leading cause, and the several studies have highlighted the emerging trends of antimicrobial resistance in ocular infections. Early TPK for infectious keratitis will have a better outcome. T-DALK should be considered a surgical option for infective keratitis, and T-DALK should be promising, gives a promising results, but it has got its own challenges, and like correct diagnosis of the depth of the organisms, and for that you should have a confocal microscope, and surgical expertise to do a DALK also is needed. Thank you again. These are my references. Thank you once more.
Any questions from the audience? Okay.
Thank you, sir.
Thank you for your patient listening.